for today. So please, let's put our Father Christmas list together. Let me clear my throat before I mention his name. He's no other than Dr. Fred Adumakumbuateng, the Ashanti Region Health Director. Thank you so much for agreeing to do this, Dr. Adumakumbuateng.
Thank you. So I think I now have the opportunity to briefly respond to this, but distinguished guests, esteemed colleagues, and especially when you are using this term colleague, it brings to mind. You remember a gentleman was asked to do a presentation, and then in his welcome address, he said, ladies and gentlemen, and then colleagues. And after the presentation, I understand some emeritus professor went to him and asked him, me and you, are we colleagues? But ladies and gentlemen, good afternoon. Indeed, I am honored to be called upon to chair the launch of the Prematurity Awareness Month celebration for this year. As you know, premature birth over the past decade has emerged as a key public health concern globally. And in Ghana, the preterm birth rate has increased with a current average national preterm rate of 14.5%, a rate which is actually higher than the global average of 10%. Despite significant strides in newborn care in recent years in the country, prematurity and its associated complications is a significant contributor to neonatal morbidity and mortality. In the Ashanti region, data from 2023 and 2024 indicates that prematurity and its associated complications are among the top 3 causes of both neonatal admissions and mortality. The rising rates of preterm births and the significant morbidity and mortality associated with it, especially in the neonatal period, is indeed a challenge that calls us all to action, to innovate, and to ensure that these newborns, irrespective of where they are born, have access to high quality care. I'm therefore elated about the celebration of this year Prematurity Awareness Month by the Pediatric Society of Ghana, and particularly inspired by the theme, Breaking Barriers, Access to Quality Care Everywhere. And indeed, if you look at the recent Global Commission on Quality, quality now is the leading causes of all mortalities, irrespective of the increase in geographical coverage that we have. But suffice me to say, the barriers to high quality care are numerous: geographic, economic, and even sociocultural. Lack of equipment is one of the major challenges in newborn care in the country. For example, out of the 42 newborn units in the Ashanti region, 25, and basically only 60% of them do not have conventional CPAP devices, which is supposed to be part of the minimum care package for the management of preterm infants as recommended by the World Health Organization. Yet, we know that with determination and collaboration, these barriers can be surmounted. Our commitment to breaking these barriers involves several key actions. First and foremost, we must advocate for policies that support accessible and affordable health care for all. We must work towards reducing the inequalities that prevent access to essential medical care by ensuring that we build capacity at our primary levels of care and eliminate barriers to prompt transfer to higher levels of care when indicated. Secondly, we must invest in training and resources for healthcare professionals at the various health facilities. The care of the preterm newborns have seen significant innovation globally that have resulted in improved short and long-term outcomes. and therefore ensuring that healthcare facilities are adequately equipped with life-saving equipment such as CPAP machines, oxygen blenders, and clinical monitors, coupled with regular training or updates for healthcare personnel on care of the preterm infant, will go a long way to ensure quality care provision and improve outcomes for our babies. Additionally, we must promote family-centered care in all our facilities and foster community support systems that will provide emotional and practical assistance to families navigating the challenges of preterm birth. Lastly, we must continue to support research and innovation in neonatal care. By investing in research, we can develop new innovations and interventions best suited within the local context to improve outcomes for our preterm infants. To conclude, I would like to commend the PSG for its unabating advocacy for babies born premature and commend the PSG Ashanti for the hard work behind the scenes to ensure the success of this awareness creation and advocacy. I want to reaffirm my personal commitment to work together with all relevant stakeholders to break barriers and protect the rights of these babies to high quality care. Together, we can create where every preterm newborn everywhere has the opportunity to receive quality of care and thrive. Today, as we launch the Prematurity Awareness Month, we acknowledge the strength and resilience of healthcare professionals, the courage of parents, and advancements in medical and care that together help us move closer to a world where every child has the best possible start in life. I hereby declare the 2024 Prematurity Awareness Celebration duly launched. God be with us all, and thank you very much.
Thank you so much, Dr. Fred Adumaku. Dr. Fred Adumaku Boateng, if I may, I believe that the other name is Babiton, for those of you who don't know who our chairperson has been in the past. So Babiton. So thank you so much, Director, for this wonderful and inspiring message that you've given to us. And thank you even more so for the commitment that you have pledged to support the region and even Ghana as a whole in improving the quality of care that we render towards our premature babies. Indeed, to help them survive and to help them thrive as well. Thank you so much. We could not have asked for a better chairperson or for a more inspiring remark than you have given us today. Thank you so much. So, ladies and gentlemen, it's almost about time for us to enter into the second part of the program. And the second part of this program is the CPD, in which we're going to talk about retinopathy of prematurity, and we're also going to talk about respiratory support for preterm babies. But let me ask you in 2 seconds, Stevie Wonder, Albert Einstein, Napoleon, what do all these people have in common? If you know, you could just put it in the chat. You could just drop it in the chat. What do they all have in common? Stevie Wonder, Napoleon, I hear Nelson Mandela, Einstein. What do they have in common? Can you drop it in the chat for us to see? As Dr. Nana also gets ready for her presentation, can you drop in the chat? What do they have in common? Somebody doesn't know who Stevie Wonder is. Somebody says they all have in common blindness. Okay. Somebody says they are all heroes. They are all born too soon. I like this. Any more answers? They're all heroes. They're all born too soon. They're all very intelligent. Anything else? They're all preems. They're all preemies. Anybody else? All right, so you're right, and they all made an impact, and they're all preterms. So the answer that is running through all of this is that they are all preterms. And you're right, all of them are noted to be preterm babies. Now let me test your music knowledge. Which famous one song did Stevie Wonder sing? Famous song sung by Stevie Wonder. Somebody's wishing I'd rather ask for Shaka Wale's song or Black Sherif song, so you can play, or as Nana likes, King Palute's song. But which one popular song did Stevie Wonder once sing? Anybody? Just called to say I love you. Hey, you've been enjoying the song. Yes. So Stevie Wonder sang in the past, I just called to say I love you. I just called to say how much I care or something like that. I can't even remember the words. But Stevie Wonder was an ex-prem who became blind because he had retinopathy of prematurity. But before we dive into retinopathy of prematurity, we're going to take a very interesting presentation by Dr. Nana Rekubrube, and she's going to talk to us about safe and efficient respiratory support for our preterms, our preemies. Nana is a neonatologist who works at Konfanochi Teaching Hospital. I know that she'll not want me to say this, but Nana is somebody you can call on at any time of the day. She'll respond. She'll give you the support you need. If she even needs to really squeeze to make care for a critically ill baby, she will do so. That's who Nana Rekubrube is. And alongside all that wonderful work that she's doing, she also loves wachi. Any form, any type of wachi, whether it's by the gutter, whether it's in a tree, whether it is in a restaurant, as long as it is wachi, she likes it. So at the end of her presentation, you are awed by what she says. Send her some wachi, and I'm sure she'll be grateful. Nana, our ears are all yours. I realize a few are asking in the chat whether we can have a link to register for the CPD. The link will be put up for us in a couple of minutes. The link for the CPD, yes, it will be put up for us in a couple of minutes, and it will be posted in the chat also. So don't worry, it will be posted soon before we are done with the program. Don't worry. I have a feeling that our speaker has just paused to go and grab the last spoonful of water before she comes back to join the presentation.
Aduma, my apologies. Somehow it just went off. Can you hear me now?
Yes.
Yes,
Can you
we
hear me?
can see. Yes, and
All
we can
right.
see the screen now.
Okay, great. So good afternoon again. So my task is to do a short presentation on safe and efficient respiratory support for preemies. So quickly, we'll go through a few factors that impact on respiratory care for the preterm infants. For the purposes of this presentation, the focus would definitely be on the preterm infant. So by way of introduction, respiratory distress is one of the most common problems neonates encounter within the first few days or weeks of life. Respiratory distress is the most common cause of respiratory distress in preterm infants. And as we all know, the incidence tends to increase with decreasing gestational age. So the more preterm the baby is, the higher the risk, and then the higher the incidence, as well as the severity. It is also the most common complication of prematurity, and it can lead to significant illness, even in the late preterm neonates, and cause death as well. Management of the complications of prematurity has been identified by WHO as a target area if you want to improve or reduce neonatal deaths. So if you focus on just the proper management of the complications of prematurity, there's evidence that you can make a significant dent in neonatal death. So if you have a baby who has respiratory distress, that baby has a 2 to 4 times chance of dying compared to one who does not. So I brought in this slide for us to appreciate the fact that whenever you're talking about babies, you cannot talk about babies without talking about mothers. The continuum of care is very important, and it should start even before the pre-pregnancy period. So the pre-pregnancy period where the reproductive aged woman is supposed to be on folic acid, iron, etc., all leads to a better pregnancy experience. And we all agree that the survival of the child is intricately linked with how the mother does, especially during the pregnancy. So whatever interventions you put in place during the pregnancy period is likely to have an impact on the outcome of the pregnancy. That's why it's important that the mother has to stick to her antenatal clinic visits routine, because that is when the obstetrician is likely to pick up medical conditions like hypertension and diabetes that can impact on the fetus. Then also the need to be given antenatal steroids between 24 to 34 weeks for mothers who are likely to go into preterm labor. So if you look at the picture, you'd see that the obstetrician is more like the chef. So whatever ingredients the obstetrician puts together in the kitchen, in the end, whatever comes out is what the obstetrician will hand over to the pediatrician. So it's like you have no option but to work with whatever the obstetrician gives you. So it's a very important continuum. So pre-pregnancy, pregnancy, antenatal care, even the delivery period. So emergency obstetric care, and then the ability to resuscitate. Studies have proved that when the HBB program is implemented, is able to reduce intrapartum related stillbirths by 38%. It can reduce overall mortality by 33%, and then also reduces first day neonatal mortality by 30%. So you see that all these contribute to reducing mortality. Now, respiratory care cannot be isolated. It cannot sit on its own, okay? The supportive measures that go along with it have a huge impact on the outcome of the baby. So this is just something that I put together, but I forgot to include infection prevention and control. That one is supposed to be at the background in all that we do. So if you take, say, thermal care, you realize that if a baby is cold, there's a chance that the baby could end up with hypoglycemia. Then the baby can end up desaturating as well, invariably affecting the way the baby would be breathing, its ability to spontaneously breathe. If the mother does not start breastfeeding early, it increases the chances that the baby could end up with an infection or even die. Not providing KMC can result in hypothermia. If there's an infection, you do not start antibiotics early, baby can quickly deteriorate. It can present as respiratory distress or even apnea. So you realize that they are all sort of interlinked. If you do not have a proper transport and referral system, I mean, we all agree that no, not all health facilities are on the same level. So if somebody comes to deliver in your facility, baby comes out, the breathing is too much, or the baby is in severe respiratory distress that you cannot handle, there should be proper transport and referral facilities for you to be able to move the baby for advanced care. So all these measures tend to be interlinked. So the first one is hypothermia. WHO defines hypothermia in the neonate as an axillary temperature below 36.5. I think in 1997, they came up with several of the different grades of hypothermia in the newborn. So you have the normal, which is between 36.5 and 37.5. And then mild hypothermia is between 36 and 36.5. So here there's cause for concern. And it's such that if you detect it early and you put measures in place, doing KMC, bundling up the baby, putting on a hat, increasing the temperature of the room, etc., the baby immediately warms up. Then moderate hypothermia is between 36 and 32. Here, the baby is definitely in danger. And we tend to have quite a number of our preterm babies who have been referred. During the transport, they tend to lose a bit of heat, so they arrive and their temperatures are below 36, which can be concerning. So here, the baby is in danger, all right. But like I said earlier, if you put in measures quickly, the baby can come up. Severe hypothermia is when the temperature is less than 32. And here, the baby is definitely circling the drain unless you put in skilled care immediately. So studies have revealed again that newborn admission temperature is a strong predictor of mortality and morbidity, regardless of the gestational age. So it's been found that for every 1 degree drop, less than 36 degrees on admission, increases the baby's chances of one, dying within the next 4 weeks by 28%, sorry. And then it also increases the chances of the baby developing late onset sepsis by 11%. So hypothermia, unfortunately, tends to be underrated, but it's doing a lot of harm. And these are things, it's one thing that we need to keep an eye on. You can have all the equipment, all right. You can put the baby on CPAP, high flow, whatever. But if the baby is cold, you will not see any significant improvement. So that brings us to the warm chain. So the warm chain is a set of 10 procedures that are sort of interlinked. And these are measures that are supposed to be instituted during birth and immediately after. It could be hours and days after the birth, all in a bid to reduce the baby's chances of becoming hypothermic. So the first one is the warm delivery room. WHO recommends that the prevailing temperature in the delivery room should be at least 26 degrees Celsius. Remember that the fetus is coming from a warm environment. Unfortunately, the fetus is expelled into a relatively cold environment. So naturally, if the temperature in the delivery room is not increased, there's a chance that the baby will lose heat to the environment. Then warm resuscitation. You need to provide warmth for the baby. So radiant warmer should have been switched on even before the baby comes out. Then as soon as the baby comes out, you want to do thorough drying. Another thing that I've realized helps is that once you switch on the radiant warmer, you can place the cot sheets underneath the radiant warmer. So by the time the baby comes out, the sheets are all warm and toasty, and it helps boost the baby's temperature quickly. And bear in mind that as soon as you dry the baby, you need to discard the wet cloth and then replace it with a dry one. Then, of course, we all know the benefits of skin-to-skin contact. And the earlier it is done, the better. And the longer it is done for also, the more the baby benefits from not becoming hypothermic. Breastfeeding. We all know the advantages, the benefits of breastfeeding. Whenever we are asked benefits of breastfeeding, then we all rattle it. Okay, but the practice can be a bit difficult on the ground when you have a mother who is struggling to breastfeed, or when a mother has had a CS, when to initiate breastfeeding, etc., etc. But definitely breastfeeding also contributes to providing warmth to the baby. Then bathing postponed. I want to believe that the practice is going down. We don't bath our babies as soon as they come out now. The teaching is that you only bath the baby when the baby is soiled, especially in situations where the mother is retropositive. But otherwise, if you must bath the baby, then at least wait for 6 hours. Okay, if not, then after 24 hours is fine. Then appropriate clothing and bundling. So essential newborn care teaches us that the baby should have on at least 2 or 3 more layers of clothing, in addition to what you, the adult, you're wearing to feel warm enough. So if you have 2 layers of clothing on, then the baby must have 4 or 5. And then zero separation between mother and baby. It is only human beings who separate their mothers and babies. All other mammals, mothers and babies stay together. Okay. Then professional alert. So there's a need for healthcare workers to appreciate, to be very much aware of preventing hypothermia. So once you're aware of that, that means that you you try to keep all these measures in place, ensure that the temperature in the delivery room is correct, immediate drying, you switch on your radiant warmer, everything. So the healthcare worker has to be very conscious about the harm hypothermia can do and put in measures to prevent these. Then the last one is warm transport. Okay, ideally, if the baby can be transported in skin to skin, that is the best way to prevent hypothermia. Skin to skin has been found to reduce hypothermia by what? KMC has been found to reduce hypothermia by 80%. So that brings us to kangaroo mother care. So on the top right, you see a father who is doing skin to skin for his twins. And then underneath that, you see a very tired mother who is also doing skin to skin for her baby. So the biggest benefit of KMC is prevention of hypothermia, but there are other benefits as well. Facilitating breastfeeding, also improving lactation as well. And once a baby is getting more breast milk, there's a chance that the hospital stay will be shortened. And then also, of course, it improves mother-baby bonding. So breastfeeding, the last time I was asking whether we still have the baby-friendly hospital. Some time back, I think there was this practice where you'd have an accreditation team coming in to see whether your health facility qualifies to be BFHI accredited. I don't know whether it's still happening. But breastfeeding is a major part of preterm care, breastfeeding and breast milk feeding, of course. So in Kintampo, just in our backyard here, it was done some years back, but it involved quite a number of babies. I've forgotten the figure. I think it was more than 10,000 or so. And they came out to say that if the mother initiates breastfeeding within the first 24 hours of life, it reduces the baby's chances of dying by 16%. But if she initiates it within the first hour of life, it reduces the chances of the baby dying by 22%. So breastfeeding should not be taken for granted. The next one is oxygen therapy. So this one is more like in line with what we're talking about today. In recent years, we have been using a lot more oxygen, especially since the COVID time. Oxygen is one of the most commonly used drugs in the clinical setting, and there's no doubt that it saves lives. However, we seem to have a practice where we use it, should I say, indiscriminately. Its use must be carefully considered because, I mean, oxygen is a drug, and like any other drug, if you abuse it, it will abuse you back. Okay, and in the end, you will lose. Infants who have been resuscitated, those with respiratory distress, those who are hypoxemic, granted, they can be put on oxygen. But the issue is how we monitor our babies on oxygen, especially with preterm infants. Too much oxygen is bad, and then too little oxygen is also bad. So there must be a limit somewhere. Pulse oximetry ideally should be performed on all babies who are hospitalized, those with respiratory illnesses, emergency signs, hypoxemia, etc. This is not me saying it. I mean, this is in our IMNCI guidelines. So ideally, all babies who are on oxygen should be on a monitor or should have some kind of oximetry, pulse oximetry happening. Please, can you hear me?
Yes.
Oh, okay. Now, in practice, there's this common misconception is that you cannot give too much oxygen or oxygen won't hurt, or once the baby is saturating at 100, you are cool. But that is not the case. A baby on supplemental oxygen should not saturate at 100%. Now, there are monitoring targets. The target range is between 90 and 95. And this one was taken from the Ghana Health Service oxygen therapy and then the CPAP protocol. So if a baby is on oxygen, you're aiming for 90 to 95. Now, I picked this from the WHO recommendations for the care of preterm or low birth weight infants. So I selected a few of the items. Now, they've divided the care into three. So you have three categories: preventive and promotive care, care for complications, and then family involvement and support. Now, under preventive and promotive care, providing KMC, both immediate and at any time, has a strong recommendation with high certainty evidence. So studies have proved that indeed there's great benefit when you provide KMC at any time. Then early initiation of enteral feeding, also strong recommendation. Now, I brought this here because I wanted to mention CPAP. We cannot talk about oxygen or respiratory support in preterm infants without mentioning CPAP. So under care for complications, WHO puts CPAP for respiratory distress. And it says strong recommendation, moderate certainty evidence. Same for methylxanthines for treatment of apnea. That's for your caffeine citrate. Then, of course, you have your family involvement and support, which is important since we're trying to lean more towards family-centered care. So family involvement and then home visits. So CPAP, I mean, we've been making a lot of noise about CPAP of late. One of the advantages of CPAP is that it's non-invasive. So then that means that less skill is required to use it in the neonatal ward compared to putting the baby on mechanical ventilation. So it's the application of positive pressure to the airways of a spontaneously breathing infant. The air mixture you're providing is supposed to be heated and humidified. Now, the clinical goals of CPAP is to maintain what we call functional residual capacity in the lungs. When we say FRC, we're talking about the amount of air that remains in your lungs after you've exhaled. Okay, so passive exhalation, when you breathe in, when you breathe out. So after you breathed out, the amount of air that remains in your lungs is your FRC. In the preterm infant, because their alveoli sizes are so small, when they breathe out, there's a chance that there's very little air remaining behind in the lungs. So then that means that the alveoli will collapse. And then when they're breathing in again, they have to work hard to open as many as possible. And CPAP comes in because it's continuously pushing in positive pressure into the airways. That means that more air will remain behind. So it reduces the chances of collapse of the alveoli, and the baby doesn't have to work so hard to open these alveoli. So that's why whenever there's evidence of work of breathing, increased work of breathing, CPAP is your best bet. And by increased work of breathing, I'm talking about tachypnea. WHO says when it's more than 60 cycles per minute. When there's cyanosis, when there's grunting, when there's flaring, when there's intercostal recessions, when there's lower chest indrawing. Generally, you want the PEEP to be between 4 and 6. So the PEEP is basically like the pressure you want to, the amount of pressure you're putting in. So the higher your PEEP, the more bubbles, and the more bubbles, the more pressure you are generating. For most CPAP devices, the PEEP, they say make it between 4 and 6, but it also depends on the brand of the CPAP. So I put this here, recommended alarm limits. So we have an idea. In room air, the baby can saturate at 100%. Yeah, I've been told I should say on room air, not in room air. So if I say in room air, please forgive me. That's what I'm used to. But once a baby is on supplemental oxygen, the baby should not saturate at 100%. So if a baby is saturating at 100% in on supplemental oxygen, then you have to what? It's time for you to wean the FiO2 for the baby. So these are a few nursing considerations that I put up. During rounds or an admission, you must get the one doing the rounds, you must get the doctor to specify the target SpO2 range, because that is what you're going to base your weaning on. Then always try to wean. Always try to wean down. When you're given supplemental oxygen, the baby should be on the least amount that will make him or her saturate within the target range that has been set. So if a baby can saturate between 90 and 95 at an FiO2 of say 45% or 40%, the baby should not be on an FiO2 of 60%. That means you're giving too much oxygen. We are not seeing the effects now, but later on, the baby could come back with complications from the high amounts of oxygen the baby got. And whenever you're stopping supplemental oxygen, it's best to do that when during a shift when you have the highest number of staff. In most places, it tends to be the morning shift. So if there's a chance that the baby can be weaned off oxygen, then do it in the morning. So that if the baby does not tolerate being in room air, then you have enough staff to handle and react to the situation. But if you have one nurse per the night shift, that is not when you are going to be adventurous and try the baby in room air. Then there are times we've had situations where the oxygen or the SpO2 probe wrapped around the foot or the arm, the hand, and the preterm infants, because they're so delicate, part of the foot actually became gangrenous and then fell off. So you need to observe where you've wrapped the probe for possible pressure areas, okay? And ideally, from some protocols I've seen, what they do is that they change the probe position like every shift. So it's like every 8 hours, they come and change the probe position, because some of them, you have no idea how tightly you've wound it around the hand or the wrist. You come back the next time and it's been blue for a long time. And of course, for all critically ill babies, you want to apply it to the right wrist or the right hand. Otherwise, then if the baby is not critically ill, baby is stable, you can apply it anywhere. In situations where pulse oximeters or monitors or vital sign monitors are not enough or not available, so that means you cannot do continuous SpO2 monitoring, then the SpO2 must be considered like a vital. So if you go around taking the vital, say every 3 to 4 hours, then you must have one portable SpO2 device that you'd be taking alongside to be measuring the SpO2, just so you have an idea of how the baby's SpO2 is trending. Then another source, another issue is with the humidifier bottle. So we, some time back, we had a situation where there were 3 babies, there were 3 incubators, following each other, sitting next to each other in acute preterm ward. And it's almost like all the babies who ended up in those incubators, hitherto, if they were stable, suddenly sort of deteriorated. I think we even lost one. And then we did blood cultures on them, and I think 3 of them or so ended up having Pseudomonas aeruginosa. And it turns out it was from the humidifier bottle, from attached to those incubators. Sometimes there's a tendency to forget to change the water. Okay. I suppose I'm reluctant to say this, even though I have to say it, where the ideal situation is that every 24 hours, the water has to be changed. However, if that is not possible, especially in areas with very high numbers of babies, then at least once you're changing over the baby, okay, you're cleaning the incubator and all that, the water in the humidity chamber of the incubator, as well as the water in the humidifier bottle, the containers must be cleaned thoroughly, and then the water inside changed. So just a few harmful, something small on harmful effects of oxygen. The effects are mostly seen in preterm infants, though term infants are not exempt. Then chronic lung disease or BPD. So basically BPD is the need for supplemental oxygen, even when the baby is at least 28 days old. So the baby would have been on oxygen since birth. Studies have revealed that early initiation of even CPAP can reduce the risk of BPD. Then there's retinopathy of prematurity, ROP. So basically is disorder of the eyes, the retinal aspect of the eyes. It's typically associated with preterm infants, and it's got to do with high levels of being exposed to high levels of oxygen. So in utero, the retinal vessels, in utero is a bit hypoxic. So the retinal vessels are sort of growing well in that quote and unquote hypoxic environment. And then suddenly the baby comes out and is exposed to high levels of oxygen. Because when they come out, there's a 90% chance that they would be put on supplemental oxygen. So now the body that was accustomed to the low levels of oxygen, the retinal vessels, because they are now exposed to this, the growth is sort of suspended. Then suddenly you remove the oxygen and then there's erratic growth. Dr. Ahmed will explain it better. Maybe I'm not saying it well. But so Kath, we are fortunate enough. We started ROP screening mid-August. And so far, about 200 babies have been screened. And 3 of them have had surgery. And I think two are actually supposed to have had laser surgery today as well. So you see that we tend to take it for granted because, the babies who had the surgery, 2 out of the 3 who had the injection, they had fairly normal admissions. It was one who had a very bad admission with a pneumothorax and all that. But even then, it was quite surprising when they were screened and found to have ROP. Nephritizing enterocolitis is also another complication where basically the gut is just rotting away. Okay. Then there's intraventricular hemorrhage when they bleed into the brain, and one of the common manifestations is hydrocephalus. So the next thing I want to talk about is transport and referral. Now, every time a baby is transported from one place to another, transport has taken place. So a baby from the labor ward to the neonatal unit, transport. Labor ward, postnatal unit, transport. But of course, the biggest transport is from one facility to the other, since not all centers can provide the same level of care. So you realize that transportation is what? Very vital. Ideally, there should be an adequate means of transport. You'd want an ambulance with a large oxygen cylinder. And then, of course, there should be a driver available. Sometimes there's an ambulance, but there's no driver, or the driver is there, no ambulance, or both are there, but the parents have to pay for fuel. Now, the goal of a good transport or referral involves taking the right baby at the right time by the right personnel to the right place via the right means of transport, and all the while baby receiving the right care and monitoring. Okay, so the keys to this would involve good pre-departure preparations. And I always say this, that when it comes to referral, the best managers or organizers would be the nurses. Okay, they know how to multitask and put everything together. Okay, so adequate oxygenation for the trip, thermal control, and then of course, professional nursing supervision. Sometimes you have the nurse accompanies because just in case the baby deteriorates, the nurse should be in a position to what? Help with resuscitation. And the nurse should also have information about the baby. Sometimes you have a nurse accompanying the baby, they get there, you ask the nurse, and then she's like, oh, I'm just a rotation nurse. I was coming for afternoon shift. When I got there, no, then they said that I should come with them. So one, the rotation nurse is not conversant in resuscitation. Two, she has no idea about the history or anything, the details regarding the baby. So it's vital that whoever is accompanying should have an idea. So this is just a few referral letters that I put up here to emphasize the need for good documentation. I mean, when you're referring, communication is very important. We've had referral letters where, see the very first one on your left, it is the mother's date of birth that has been documented here. Okay. I mean, granted, if this referral letter is supposed to be for the baby, then what do we need the mother's date of birth for? Okay. Then the diagnosis is baby with a problem. That is it, nothing else. Let me move to the next one for the sake of time. Why did I even include this one? So for this one, again, date of birth, you see that is what? 9th December 1981. Then age, they've written less than 24 hours. Okay. Meanwhile, the time when the, how do I put it? It's possible that the referral was written at 8:42 a.m., but you have no idea what time they eventually left the facility. So if you don't have the baby's time of birth, in cases of calculating IV fluids for how old the baby is, when the baby is jaundiced, you want to know how the baby is in days and hours to be able to plot it well. It all becomes difficult because you do not write the baby's date and time of birth. The last one I included because, so the temperature on arrival was 35.6. It is always best to ensure that you have normalized the baby's temperature before they leave the facility. Remember, like I said, hypothermia plays a huge role. So if the baby becomes cold, even before arriving at the receiving facility, it's already reducing the baby's chances of survival. So this is just a few, a slide on the essential things that's needed for a baby's transport. Unfortunately, the special initiative ambulances, they are not exactly baby friendly. So most of the things would have to be, you'd actively have to look for the things and put them in the ambulance. So when you're referring, like I said, good communication. It is vital that you communicate, one, with the parents and relatives, and two, with the hospital that is potentially going to receive the baby. And the referral process is a continuous affair. I mean, we've had situations where the parents get to the receiving hospital and they're already upset. They have no idea why they're being referred. But again, if you go back to essential newborn care principles, remember that once the mother gets in, even before she delivers, you're supposed to inform the mother that in the event that the baby comes out, God forbid, but in the event that the baby comes out and there's a problem that we cannot handle here, typically we tend to refer our babies to hospital A, hospital B, so that at the back of her mind, she knows that there's a slim chance, if anything at all should happen, the baby would what? Be transported. But you do not wait till the very last minute when all the arrangements have been done. Then you go and tell her that we're sending your baby to so and so. It has to be communicated to the relatives as soon as possible. This is all part of family-centered care. And like they say now, if it is not written, it is not done. Communication, documentation is very, very important. So take home messages. Why does this thing cover here? So regarding oxygen, definitely we all agree that it's essential for the normal functions of the body. Both too little, too much, harmful to neonates, especially preterm infants. And it's vital that you do pulse oximetry if the baby is on oxygen. Monitor the baby. There's no such thing as the baby has to be saturating at 100%. So, in conclusion, breaking barriers, access to quality care everywhere. That is the theme for this year's World Prematurity celebrations. Can we boast of access to quality care everywhere? If not, how are we going to break the barriers? This is just something on the entire WHO recommendations for the care of preterm infants. So they've broken it down, like I said, preventive, care for complications, family involvement, and support. And this is baby Kweku. So baby Kweku was 1,300 grams. And this is baby Kweku in his full uniform now. These are my references. Thank you very much.
Thank you so much, Dr. Nana Rekugobe, for that presentation. I know a lot of you have questions that you'd like to ask, but there's a time for the questions that will be after the second presentation. Just a quick reminder,
nobody has any question. Nobody has any question.
Just a quick reminder. The link for the CPD registration is in the chat box, so you can just refer to it, click on it, and then register for your CPD points. We will take the second presentation now, and the second presentation has a very intriguing title. It's The Eye on the Future, Protecting Preemies from Retinopathy of Prematurity. As Dr. Nana said earlier, sometimes you have doctors, nurses coming in, akulawe, man, oxygen kakra, as if say it is what? Apeteshi, but you realize that oxygen is a drug and must be given scientifically to the babies who need it. Dr. Ahmed is going to take us through what retinopathy of prematurity is, how we can prevent it, and what should be done about it. Many of us have grown up thinking that retinopathy of prematurity doesn't exist in Ghana, but we know that Dr. Ahmed is going to open our eyes, literally and figuratively, to the incidence of retinopathy of prematurity in Ghana. And those of you asking about the presentations, it will be made available to you. So you can calm down and let's take the second presentation. Dr. Ahmed, over to you.
Thank you very much, Adoma. I'm trying to maybe Nana can stop screen sharing. Okay. So give me a second. Okay. Do we Nana? Hello?
Yeah, Ahmed.
Yes, I think I'm having some challenges uploading so
Oh,
maybe
okay.
we can upload the one I shared with you.
Oh, all right. Okay,
Sorry
just
about
give me a few minutes, then I'll do it for you.
that.
Okay, let me see. Okay.
So, by way of information, does anyone have an idea who the youngest preterm to survive in the whole wide world is? Can you drop it in the chat if you know the name of the child? And now don't go to AI and chat GPT and whatever. Does anybody have an idea who's the youngest preterm who has ever survived? You can just drop it in the chat and then let's see. And then the gestational age, youngest baby to ever survive, and then the gestational age. Silicon was going to ask ChatGPT. That is banned, my dear. Curtis, yes, Joshua's right. Curtis means the youngest preterm to ever survive, a 21 weeker. I wonder the challenges that we would have had in Ghana helping such a preterm baby survive. With the oxygen support that Nana talked about, the KMC, the feeding issues, etc. I wonder the task it would have, how difficult it would be for us to help such a preemie to survive. But let me ask you in the chat, what's the youngest baby that you have been able to help survive in your facility? You can just drop it in the chat as you're sorting out the technical issue. The youngest baby that you have helped survive in your facility. So you write your facility name and then you write the gestational age. For instance, Hope Exchange, 24 weeker, Kolebu, 20 weeker, etc. I hope I'm not going to see Asaman SDA 40 weeker. Emmanuel Okwan, I hope you didn't hear that. All right, Ejiso says 29. Whoa, way to go, Ejiso. Anybody else? All right, so we are set. So Dr. Ahmed, let me hand over to you. I'm still seeing interesting things in the chat, but I'll come back to you later.
Thank you very much. Sorry for the technical challenge. I think Nana touched a lot on my presentation, but so great job, Nana. So the title of this presentation, Eye of the Future, Protecting Preemies from ROP. And I added establishing a retinopathy of prematurity screening as standard of care in Ghana. So for the longest time, over the past maybe more than 5 years or so, I know that the eye clinic, together with the pediatrics, the MBU has tried to establish an ROP service at CATH. And it's been extremely challenging. One, because of the number of ophthalmologists and because of the way we looked at doing it. But thanks be to God, things have changed. And currently, I'll say that we have a very robust ROP screening program at CATH. And I'll probably say it is the first of its kind in Ghana and maybe the third in sub-Saharan Africa. Next slide. Next slide, please. Yes. So who is this person? Um, when I was listening to the earlier presentations, I heard names like this person. Who knows who this is? Steve Wonder, exactly. And I heard Einstein, and I heard all these people were primates. But Steve Wonder, and I'm sure, I don't know whether a lot of people know, but we know he was blind, famous musician, pianist, singer, but he was blind from ROP. So what is ROP? It is a retinal vascular condition in preterms, where there is incomplete vascularization of the peripheral retina, and was initially described in 1942. And it is the leading cause of childhood blindness worldwide. In utero, the retinal vascularization usually starts around 4 months. Okay, now when you look at the back of the eye, there's the nasal retina and there's the temporal retina. Usually by about 8 months, vascularization of the nasal retina is complete. And then the temporal retina usually is completed sometimes after birth, 1 month after delivery. That's at 10. But hypoxia, in utero, hypoxia is kind of, helpful, because that is what helps. You need some hypoxia in vitro to cause the vascularization to continue or to happen. So in utero, there isn't 100% oxygen. Okay, so you can imagine that you have a baby that comes out and all of a sudden they have this 100% hyperbaric oxygen. Okay, what it does is it leads to damage, O2 induced damage to the vessels. Okay, and it retards the retinal development and it causes incomplete vascularization of the retina. Okay, and when that happens, there are certain inflammatory cytokines. We call them anti-VEGF. This is a bit technical. Okay, and that leads to ROP. Okay, next slide. So oxygen is essential in keeping premature infants alive, but too much oxygen can lead to lifelong blindness. Okay, prolonged exposure to oxygen can damage the eye. Next slide. Okay, what's the problem in sub-Saharan Africa? In developing countries, ROP is becoming a more common cause of childhood blindness. As the survival rate for premature infants rises. I remember when I was in medical school, my lecturers used to tell me that there's ROP, but in their time, there wasn't a lot of ROP. And this is because, like Nana mentioned, now care has improved. At that time, I'm sure babies at 20 weeks and 24 weeks were not surviving, so we're not seeing ROP. But because now neonatal care has improved significantly, you have babies surviving, and all of a sudden, ROP has been reborn again. So we have about 2.5 to 3 ophthalmologists per million population in Ghana. We have 4 million babies are born preterm. And then babies that are born, I think you've covered that slide. Maybe we can move the mouse. No, can we go back? Forward.
Just a minute. This one?
Yes. So half of all babies, so it covers half of all babies that are born preterm become blind. And to date, you have only 2 nations in sub-Saharan Africa. That's South Africa and Kenya that have developed strong ROP screening guidelines. And I'm happy to say that Ghana is probably next in line to be the 3rd country. Next slide. So the thing, protecting preemies from ROP. And so I broke it down into 3 prongs. There's prevention, monitoring, and treatment. And so prevention happens at the MBU, at the various NICUs. Okay, let's go next slide. And how does it happen? So we have a lot of early studies with improvements in oxygen management in the US. One of them was by Cho, and he said that when you improve oxygen management, you can reduce ROP, stage 3 and stage 4, from 12.3 to 2.5%. And oxygen management definitely means that using the blenders, using the CPAPs, not giving 100% oxygen. Okay, and according to the American Academy of Pediatricians, the oxygen target in preterms or premature babies is 90 to 95%. Although this range is different based on comorbidities, we know that 95 to 100% oxygen actually does more harm than good. And I'll reiterate again that kangaroo mother care results in 1.5 times reduced risk of ROP. And this was by Banca et al. Unfortunately, in Ghana and most of sub-Saharan Africa, we are constrained because of limited resources. And so we are not able to give the proper oxygen. And so a lot of babies will receive unfractionated oxygen without constant monitoring. Okay, and so we see that a lot of them will receive nasal cannula without a blender or the CPAP machine. Next slide. Monitoring. How do we monitor? So we know how to prevent. There are different ways, and that's why years ago we'd never been able to establish ROP. So ROP screening. So we are either doing screening with indirect ophthalmoscopy, next slide, or with tele-ROP using a camera. So on the picture on the left is indirect ophthalmoscopy. So to screen, you actually need the ophthalmologist to be there. Okay, and remind you, ROP screening is not screening the baby just once at time A, but it is screening at multiple time intervals. So you screen, and then you probably will screen in 3 days, and you screen in a week, and probably every week until you are sure that that baby doesn't have ROP, or that baby has passed the risk of developing ROP. So it's a bit difficult because when you look at the number of ophthalmologists in the country, together with all the other pathology and conditions that we see, diabetes and sickle cell and all that, it becomes a bit difficult. Okay, but now we have tele-ROP screening, and I'll talk a little bit about it. We have a camera that has been put at the neonatology department at the MBU, and so babies are screened, and then these images are uploaded on a website, and you have a grader in the US and in different parts of the world that can look at these images in real time and say that this baby needs treatment. And so immediately that baby will get treatment. Or they say this baby, let's take a picture again tomorrow, or let's take a picture again in 2 days' time. And these photos are not taken by ophthalmologists, or they are not taken by neonatologists, but these photos currently are taken by nurses and are taken by trained photographers. Currently, the US guideline says that babies less than 1,500 grams birth weight or less than 30 weeks of gestation should be screened. But in Ghana, proposed guidelines, we've proposed a different guidelines. We've increased the birth weight to 2,000 grams and then the gestation of 32 weeks or less. Next. So you look at this, for ROP is progresses. So you look at the first picture as a normal retina, and then you see this first, the one that says low risk. You see a small demarcation line. Okay, so you can monitor. So when you see this, you monitor, because it's possible that this baby will not develop ROP. Their retinal vasculature will fully develop. So you have to keep an eye on them. But it's possible that this baby will progress to the moderate risk. And so you see like a ridge, okay? And then if nothing is done, they can have neovascularization, tortuosity of the vessels, and eventually they can detach, okay? And this happens very quickly. This can happen within a few days. So it's important that these babies are monitored very frequently. I'll probably also add that in the US, maybe you can put in the chat box, who can give me an idea of the suits, as in the legal suits a hospital will have to pay, okay, amount of money if a baby gets blind from ROP. You can just type in the chat box, but I'll say it anyway. So if a baby, for example, if Confanoche was a hospital in the US and a baby in the MBU got blind, one baby got blind for ROP, Confanoche will be expected to pay $40 million US. 40 US dollars. Okay. So it's a huge amount. And so what happens is you have institutions, it's a big deal because a baby that gets blind is blind for the rest of their life. And it's something that could be prevented. It's easily preventable. Okay. And so the hospitals, what the hospitals do is, and they use tele-ROP. So you have a hospital will sign or will make an arrangement with an ophthalmologist, and that ophthalmologist will make use of tele-ROP. So they deploy a camera to that hospital, they deploy trained photographers, and then they take constant pictures of these preterms. Every preterm gets a photo. Okay, and these babies are monitored on the ward. Okay, you have to be certified that you are ROP free before you are discharged. Here at CATH is a bit challenging because of the number of beds we have. And so you find out that once the babies are a bit, they gain some weight and they are not in terms of, the risk of the preterm is not there in terms of other complications of prematurity. They are discharged to come for follow-up at the weight check clinics. But what we have done is we put the camera at the neonatology, the MBU. And so screening is done there every Thursday. And then on Friday, those babies that have been discharged that come to check their weights will also get the photographs taken. Okay. And so it's done on Thursday at the MBU and on Fridays. And currently we are screening about 35 to 40 patients every single day. Okay. So next slide. Treatment. So we are monitoring. What is the point in monitoring and doing all this screening if we can't treat? And so it is multidisciplinary. So ophthalmology comes in. Next slide. And then in ophthalmology, even within ophthalmology, we have various subspecialties. So you have the retina subspecialty, you have the pediatric ophthalmology, and we work hand in hand. Okay, we know that of all babies meeting screening, about 5 to 10% will need some treatment. Now, the treatment is usually given an injection in the eye. Okay, and I'm happy to say, like Dr. Nana mentioned, that I think about 3 patients have been treated. And these patients, they received injections. And if these patients hadn't been treated, they would have definitely gotten blind. So to me, for anything at all, the whole purpose for all this screening, right? Even if those 3 patients are the only patients that could have been saved from getting blind, I think it is worth it. Okay, it's just a 5 minutes procedure or even less, cost about 120 USD. So about 1,000, things like 1,500, 1,600 for treating both eyes. Okay, given an injection in both eyes. Both of them just needed 1 injection, they were fine. You take the injection, and then we monitor serially by taking photographs. And then you see that all the signs of ROP start regressing and the retinal vasculature, starts improving. And then we can also do laser. Currently, like Nana said, there are currently 2 patients in real time now. One has already been lasered at the Cath Eye Center. Another one is being lasered as we speak, and hopefully they will not get blind from ROP. Now, prompt treatment prevents retinal detachment. Retinal detachment is a last stage. The prognosis after getting retinal detachment is bad. Okay. And so we don't want them to get there. Usually after treatment, these patients will usually become myopic. Okay. And so they will need glasses. And so the pediatric ophthalmologist needs to follow them up closely. They'll probably need glasses. And you want to even monitor them even when they are past that stage. Okay, to make sure that they are fine. And so we have a first treatment for ROP done in Kumasi on the 3rd of September, 2024. And this is that's myself with some of the CAT staff. And it was we consider it a big milestone. Next slide. How can we make Ghana the 3rd country in sub-Saharan Africa to have ROP screening? Next. So we've broken them down into 3 phases. And the goal is to establish ROP screening as a standard of care, not only in Korfanoche, but in Kumasi and the whole of Ghana. And I'm happy to also say that the program we are currently running has been endorsed by the medical director and the CEO. And so they know. Now you ask yourself, where is the camera coming from? How are all these staff being paid? Because they are trained photographers some of them are not necessarily CAT staff. They are nurses from CAT that are being trained. You want to transfer skill. As we are doing this, you need dilating drops and all that. So how is it? Because now the ROP is not under NHIA. So who pays for it? So phase 1 was in January to August of 2022. There was a site-wide census and needs assessment at CAT. So a study was done, RRB approval was gotten to find out whether there was ROP at CAT anyway. And we found out there was a lot of ROP. Okay, there was a lot of preterms, and so potential for babies to get ROP. There was a lot of unfractionated oxygen that was being delivered, very few CPAP machines and blenders. And so from August 2024, there was a camera called a 3-Nethra new camera. Okay, it's a camera, it's a contact you put on the baby's eyes, and you're able to take photographs. And the screening is done, like I said, on Thursdays and Fridays. The photos are graded mainly by one Dr. Mashfegi, who is an ophthalmologist in the Stanford University. So Dr. Mashfegi runs currently, you know what I said about a hospital contracting an ophthalmologist to screen their preterms. He screens about 43 sites in the US. So he has 43 different NICUs in the US where he's using tele-ROP to screen. So he was more than happy. He has a lot of experience. He was more than happy to add MBU, CATH, as a 44th site. Okay, he sits down behind his computer, grades all the images, and he's not had one single baby in over 20 years of experience getting blind from ROP. Okay, treatment is done by CATH ophthalmologists, and we are collecting prospective data on ROP outcomes. Now, the phase 3 is going to be the exciting part. So we have a number of partners, Value being one of them, who have agreed to donate CPAP machines, oxygen monitors across the Ashanti region. And so pediatrics is going to be having some CPAP machines and oxygen monitors soon, the MBU. And then we're going to complete on, so this is prevention. So we're going to complete the prospective data on CATH, then repeat the needs assessments in NICUs across Ghana, and then hopefully scale the telehealth program in other NICUs in Ghana. Currently, we are looking at in January or February of next year, rolling the program to the Greater Accra Regional Hospital. And we have one of our senior ophthalmologists in the person of Dr. Brima. He's a retina specialist at Kolebu, and he's leading that program in Accra. Next slide. So it's a multidisciplinary approach. And at Cath, Dr. Nana is the lead, and I'll say that she's been extremely instrumental. All this would not have been possible without her. For a program like this, you need strong leadership in terms of neonatology, from pediatrics or neonatology, because ultimately they are the ones that see the baby born. So Nana has pushed for many years, and she's continued to push and push. And I'll say after so long, this has been birthed. One of his fellows, Emmanuel Pong, has been also helpful. We have a lot of other nursing staff and other people that are probably, we can't put everyone's name here. At Cath, myself, Dr. Amy Akins, Dr. Mahmoud Tima, we have Dr. Abigail, Dr. Frimpong. She's the pediatrician, pediatric ophthalmologist, with Dr. Abigail Nyako, also another pediatric ophthalmologist. And we have a lot of collaborators that are helping from the US, like Dr. Mashfegi, Arthur Brandt, who is a mastermind together with Sathak. Arthur is a medical student, a resident ophthalmologist. Sathak is a medical student, just medical students, and have been working behind the scenes to make sure that this happens. Okay, so you need that leadership, you need that collaboration to make sure it works. And the other partners, and then you have Dr. Brimer from Kolibu. Dr. Brimer is currently in Kumasi as we speak because of the laser that I said is being done. It's not something Cath hasn't done, so we needed his expertise. He's come to train the local ophthalmologist here and all the other stuff, so that subsequently we can do laser when there's a need. We have an NGO, Africa Eye, and so the photographers is from Africa Eye. We have a scheduler. We have Vayu that is supporting the blenders for the babies. And then Hadley Health Technologies is also supplying the blenders for the babies at Cath and in Ghana. Next slide. And so this is the program at the MBU. So you see, you have the camera. Okay, so the camera is what the photographer, that's Munira. Munira is holding the camera. You have the cable around her neck. She's taking photograph of the baby's eye, and then she's looking at the laptop to capture the images. And so these images are uploaded on the website. And so, the grader grades, and then, decisions are taken. Next slide. So this is a baby that we saw day one of screening. This baby had bilateral retinal detachment and will be blind for life. Unfortunately, wasn't caught early. Okay. It could have been prevented if screening was done earlier. Next slide. Okay. So you see, why do we screen? Okay. So you see at week 4, it looks like everything is fine. And then we screen at week 5, and then we see this demarcation line. It's unfortunately, I can't project my pointer, but you see that as we were screening, we're able to see that ROP was developing. And so we had to intervene to prevent blindness in this patient. Next slide. Okay, so why do we screen? If the disease is not caught early, we'll not be able to inject. Like I said, injection is 5 minutes. The babies will get blind. Next. So here we have a slide before. There you have Nana. So Nana has also been trained to take some photographs, because Nana says in her words, I need to also learn how to take photographs so that I can also train and I can also teach. So you have Emmanuel, you have a nurse, you have Nana, and that's Arthur Brandt from Stanford. So Arthur, this is when Arthur brought the camera. And so this was the first and second weeks when it was being implemented. And I'll say it was a successful week. This program at Cath, I'll end by saying this program at the neonatology has proven to be extremely successful because of leadership, because of collaboration, right? Because of the passion. No one is being paid any extra for doing this, but we know that by working together and saving the sight of one baby is extreme, is a big deal. Okay, and we in ophthalmology, we say we are saving a lot of sight years. Okay, and so prevention by oxygen management strategies, monitoring, treatment with local ophthalmologists. We think cath, we have gotten there, and we are striving to continue to improve. And then currently, outside cath, we also have a referral. And I was happy when Nana was mentioning that the referral. So there are babies, preteens that are referred from other nearby hospitals to the neonatology. Okay, so when the baby is born with ROP and with a preterm baby is born, they are given a referral slip, and then they come to get their photos taken. Okay, and the idea is that cath will be the eventual referral site. When the numbers are overwhelming, we can consider setting up other sites elsewhere. So the key to the program is strong neonatal leadership, and we think we have that. Next slide. Thank you very much. Okay. Over to you, MC.
Aduma, are you there?
Aduma.
All right. Thank you so much, Dr. Ahmed. This has been enlightening. Whilst we wait for Aduma, I'm sure we can open up for questions. Please, are there any questions? Or is Aduma back?
Yes. So sorry. Thank you so much. This has been amazing. I have goosebumps. I saw that somebody posted in the chat, I think Arthur or someone, that a mother doesn't show up for a neuropathy screening. The police are actually sent to her house to bring in the baby for screening. This is amazing. May we get to that point where the screening is available so that we can even enforce that every single baby must be screened. This is amazing. Questions, any questions, you can put them in the chat, or you can raise your hand so that we will unmute you and you can ask your question. Any questions, please? You can put them in the chat or raise your hand. Okay, so a few questions coming in. Hey, Dr. Mukodia, I see you. Greetings, buds. All right, so somebody asked, at how many days of life, after how many days of life should the baby be screened? Could you respond to that so that those who may not be on the chat may be able to get the answer? And then somebody also asked, what are the time interval for screening? Those are the two questions thus far.
Ahmed, will you take those?
Yes, so screening is done starts at 2 weeks of life. And then the time interval, currently, it depends. So we have a protocol. So it all depends on the stage for the ROP. So if it's like a stage 1, the interval is a bit longer. We can probably do it weekly. Arthur is here. I'll let Arthur chip in as well. Arthur is one of the facilitators and spearheading of this program. And then as the ROP, supposing it's at stage 3, sometimes you may need to even screen every 2 days or daily. So it varies per the stage.
Dr. Ahmed, you mentioned that Arthur would like to chip in something. So if he could kindly unmute himself and then give the comments we're waiting for before I revert back to the chat.
Arthur is unable to unmute himself. I think maybe we need to give him some. Maybe the administrator may need to give him some.
Okay. Upon, could you kindly see if you can have a look at that? And then Aisha is asking, how do the NICUs in the district hospital screen for ROP? And Stelikem is asking, does head cooling affect the baby's body temperature? I think Nana, you will take that for us. And Selwyn is asking, can we screen 10 babies who have been on mechanical ventilation or oxygen therapy for long for ROP? This is 10 babies. And are you opening up to training other NICU staff in other facilities?
Hi, everyone. My name is Arthur. I'm one of the resident ophthalmologists from Stanford that has worked closely with Dr. Ahmed in starting these programs. So just to answer a couple questions. First, for the do you need to screen term babies? The answer to that is no. So the retinal vasculature fully develops by 40 weeks, sometimes even a week or two earlier. So if a baby is born at term, their retina should be normal and they do not need to be screened regardless of the downstream oxygen history. For the screening intervals in the US, it's a little bit complicated, but in the US, we never screen a baby before 31 weeks. And then if a baby is, say, like 28 or 29 weeks, you would wait until they're at least 4 weeks old to do the first screening. In Ghana and also in India, we're a little bit more aggressive about when we first screen. And the reason is twofold. One is because of lack of oxygen blenders and oxygen monitors, the babies are exposed to oftentimes higher oxygen toxicity in Ghana, and they can develop the disease a little bit earlier than we would see in the US. So we have actually been screening at 2 weeks of life in Ghana. The second reason is that babies are discharged a little bit earlier in Ghana. And by doing the first screening when they're still inpatient, we can communicate with the mother and explain that their baby has immature retina and is still at high risk of blindness. And we found that the compliance for the mother to come back and to continue screening is a little bit better if you do the first screening inpatient and have that opportunity to explain the disease to the mother. In terms of interval, the default is weekly until the baby is 40 weeks. If the baby has had no significant disease by 40 weeks, we can space them out to every 2 weeks until they're 45 weeks. And at that point, they are more or less good to go. Ideally, you would also have a single outpatient screening with a pediatric ophthalmologist or a retina specialist to confirm that everything is normal, because the camera photographs about 90% of the retina, but not quite 100%. But even in the absence of that exam, the risk of blindness at that point is exceedingly low. And then I think the final question, and then one more nuance on screening. And really one of the advantages of the camera is that when babies start developing significant disease but don't quite require treatment yet, it's not safe to wait a week. You have to screen them more closely. So then we would screen the baby every 2 days or so. And the good news is sometimes the disease regresses on its own and you don't need treatment and you don't need to, bring the baby to the OR, spend money on treatment and expose them to the risks, admittedly very small risk, but any surgery has risk. So you only want to treat if you absolutely have to treat, and we can just screen them more closely and still ensure a great outcome for the baby. And then for the outside facilities, I think the goal at some point in what they do in India is that they actually have a team move the camera from NICU to NICU to do the screenings inpatient. However, that incurs a certain amount of cost that we can't quite take on yet. But in Ghana, oftentimes the babies are discharged early enough that you can still screen and catch the disease while it's still reversible on an outpatient basis. So our first step is to work with all the surrounding NICUs and try to get the mothers to bring their babies once they're discharged to the NICU, and then we can screen and treat accordingly. And that should get rid of most, albeit not 100% of the blindness. long-term, a better strategy will be to have a rotating team where the camera moves to the different NICUs, but that will probably be a strategy for the future. And then the one last question I see in the thread is, can we do phone screening? And the answer to that is maybe. There's a couple studies suggesting it may be possible, but the quality is pretty low. But that's something we can definitely explore for the surrounding NICUs where the baby's unstable for discharge. But the gold standard camera that we have is much higher fidelity. And then the medication side effect is virtually zero. There have been long studies in the US looking at it's bevacizumab, which is actually originally colorectal cancer, but now is the most commonly used drug in ophthalmology for diabetic disease and many other diseases. And it has never had any evidence of, no reproducible evidence of any systemic side effects for babies.
Okay, thank you so much, Arthur. A couple of other questions. Nana, at what point do you consider putting a baby in a Ziploc plastic bag after birth to prevent hypothermia? And there was another question about whether head cooling affects the baby's body temperature.
The second question, whether what?
Whether head cooling affects the baby's body temperature.
Head cooling.
Head cooling.
Uh-huh.
Whether it affects the baby's body temperature.
Well, typically it will. It does. But I'm wondering, do we have facilities in Ghana doing head cooling? Or this is just by the way?
Okay, so maybe let me let the person who asked, okay, you can
Okay, in the
unmute and
meantime,
then
let me
explain.
answer the first question.
Yeah.
Wait, what was the first question again?
The first question was whether, at what point will you put a baby in a Ziploc plastic bag after birth to prevent hypothermia?
So typically, I know that the general practice is that in the delivery room, as soon as the baby comes out, especially those that are less than 32 weeks, they're slipped into the plastic bags. So you do not even dry the baby, you just slip the baby into it for transport to the neonatal ward and all that. So that is when you put the baby in the plastic bag. That is the most common practice.
Nana, would it not be good for maybe PSG or so, maybe during one of our presentations during this month, actually have a little bit of teaching before you start receiving babies in black polythene bags that you move to come in on referral to the hospital?
Maybe
it would be good to, yes, so it may be good to have some small presentation on it.
Yeah, maybe
Okay, and
something
Dr.
on thermal care. Sure.
Yeah. And then Dr. Mukode is asking whether there's a plan to liaise with ICU in the country to regulate the delivery of oxygen to the preterm.
A plan to do what?
Regulate delivery of oxygen preterms.
Yeah,
A plan
so
to regulate delivery of oxygen.
Yes, to preterm to prevent ROP.
Okay. Ahmed, you're going to say something.
Yes.
yeah, I was just going to say that, yes. So to that, I think for the phase 3, their value and other organizations have pledged. And so we are looking at getting some CPAP machines and monitors next year. And so this will be rolled out to NICU, to Cath and then NICUs in Ashanti region and eventually the rest of the country. So yes, so there will be, and so that will regulate the delivery of oxygen to the preterms and will hopefully avoid and prevent ROP. So that should be sometime next year, 2025, hopefully. Thank you.
If I may add,
Okay.
in as much as
Yes.
Aduma, in as much as that is supposed to be on the national level, remember that's only supposed to support the facilities. I think that within the facilities too, they have to make a conscious effort. Even if we bring CPAPs and whatnot, and you do not set alarm limits and follow them. Because in some places you realize that the alarms, when the monitor alarms go off, they're like background noise. That will just be sitting there. We don't even appreciate, or the noise doesn't register anymore. So it starts with us as well. I mean, within the unit, you have to be conscious of the fact that the art of weaning the baby, bringing it down, giving the minimum amounts that the baby would need to meet the set target ranges. And then also being sensitive to the alarms. That is where it starts from. You can have all the equipment and everything, but if your attitude towards oxygen monitoring is poor, the baby can still end up receiving more than necessary oxygen, thereby having a bad eye outcome.
Thank you very much, Nana. Whilst we wait for a few more questions, touch briefly on the head cooling, because it looks like maybe some facilities are doing it underground, but the way you asked, they've all gone into hiding now. So if you could just touch a little bit on the head cooling before, whilst we wait for any other questions.
I have to be honest, I'm a bit reluctant to go into it because I'm not sure. I want to know why the person is asking. Do you get? I mean, head cooling is a very specific thing for birth asphyxia. Do you get? And it requires a lot
Yes.
of monitoring and care and staff hands and all that. So you have to be very, very efficient, monitoring the temperature, just, cooling the head alone. And to talk about it in a setting where we haven't established protocols, we are not officially practicing it, I find it I'm a bit reluctant to delve into that. So I wish the person would reach out to me. I want to know why the person is asking.
Great. So the person who, I like the answer you've given, that's country-wise, it's not yet policy or procedure. So thank you for that answer. But the person who asked, could you kindly reach out to Dr. Nana privately and then have the discussions and then get clarity in your mind concerning the head cooling? Any other questions? Otherwise, we're about to wrap up. All right, so somebody was asking, just to recap on how do we screen for ROP in the district? Just wants a recap on that. So Dr. Ahmed, could you kindly summarize that again?
Okay, so how do we screen for ROP in the districts? So essentially, this is what is happening now. So we have babies that are born preterm. Okay, and we have our criteria. And so babies that are less than 2,000 grams in Ghana and less than 32 weeks of gestation. And so 2 weeks after birth, those babies are eligible. They are screened weekly until 40 weeks, where it's assumed that the retina is fully developed. However, in the districts, currently there are some surrounding hospitals where babies that meet the criteria are referred. We currently have a camera at CAF, and so those babies that meet the criteria will be referred to have their photographs taken. And these photographs are uploaded, and then someone does tele-ROP grading. So sits behind the computer and looking at the computer is able to, it's the same, if probably not better, like using an indirect, using your manual eyes to see. Okay, you can have different people see. However, there's a model in India whereby you have a few people, you have a team with a similar camera, and then they move around from facility to facility. So maybe every week or every few days, or, they go to a facility and then they take photographs. The photographs are uploaded. Okay, but I think Arthur mentioned that it's very resource intensive. It's a bit expensive. And so currently, what hopefully we intend to roll that out in the future. But the next thing that is likely to be done will be to probably establish other similar sites. Like, because if someone is a Mampong, it's very difficult for them to refer the baby to come all the way to Kath. Or if someone is in Ashanti region somewhere, maybe Konongo, it might be difficult. So to probably set up a similar screening program at Kath at different places in the country. And we are hoping that once it becomes a national policy there, Ghana Health Service and Ministry of Health can take it up so that they can fund it. This is currently being funded by NGO. We know that donor support with NGOs, they are not forever. So the idea is to establish and have data to show that it works, present it, try to roll it, and then eventually have the Ministry of Health take it up. Thank you.
Thank you very much, Dr. Ahmed. There's one other question here. So if your facility is outside Kumasi, can you refer the babies to CAF after they are stable, post-discharge for the screening? And then somebody is asking that as a general ophthalmologist in a district hospital, could she or he start an ROP program? And what would they need to build their capacity in that area? And another person is asking that for babies who meet the criteria, who have some other complications and are on management, how do we blend the care of the management and screening? So I'm guessing that maybe this is a baby on admission for one thing, but he's due for screening maybe in CAF. So how are we able to coordinate that?
Yeah, so thank you. So yes, so you can refer, and that's what we are looking for. But we would have to consider all that Nana said regarding the transportation of these preterms to the screening centers. But yes, you can refer them, and at least it's good even if they if they come and get the first photo taken, we have an idea. You get the first photo and you see that the retina is fully vascularized, that you are fine. But we take it and we see that this baby has ROP. I mean, every mother, so far, all the mothers that have come are so keen because no mother wants their baby to get blind. Yesterday, I saw a baby that was referred to Confanochi, the eye clinic, for the first time. I saw her for the first time. And then this baby had ROP. I sent the baby to screening. And today, we are doing laser for the baby. Okay, so yes, you can refer, and we are more than happy to screen. As a general ophthalmologist, we are happy to get everyone involved. Like I said, it's multidisciplinary. When it's rolled out, it's not only CAF that is going to be treating for the entire country, but we want ophthalmologists, neonatologists everywhere to be involved. And you can reach out to me so that we can discuss it a little bit more. And for babies that are not stable, and so sometimes, for example, there are babies that are on monitors and that are in the MBU. So for those ones, if it is necessary, you have to do the screening at the bedside. And you want to make sure that you have all the support to make sure they don't desaturate and all that. So yes, it's possible to screen at the bedside. It's just that you need to take all the precautions to make sure that it's safe. Thank you.
Okay, so we are about rounding up. So before we ask the LOC chairperson to give her closing remarks, that will be Dr. Nana. I just want to ask one question in relation to something somebody also asked. The person said, is it possible that phone cameras or something could be improvised to help with the screenings until the country gets the required cameras, because certain places is too far, like Upper West is too far to even refer. And it's made me wonder whether, is it possible that AI could have been of any help in helping us to be able to diagnose the kids who need to move on to that stage of the screening for treatment? And then after this, please ask whether they can get a phone number for discussion and for referral, to prevent mothers and families from going round and round when they get to CAS. So Nana, if you have such a number, if you could put it in the chat box while the last question is answered before you give your closing remarks.
Okay, so I'll invite Arthur to answer the question about the phone, because Arthur has strong IT background, extremely strong. He worked with Google, so he's probably the best person to answer all the questions about AI. So Arthur, I would have you answer this question if you're online.
Yeah, absolutely. So today there is no FDA approved algorithm for retinopathy of prematurity. So we would be using an unregulated algorithm if we were to go that route. I think within a year there will be an algorithm, but it will not be for cell phone photos. It will only be for photos with the very expensive cameras. But I don't think you need AI. We have human graders that are willing to volunteer their time. If we want to go the route of considering using smartphones to get images, that's certainly something that we can explore. And if anyone wants to reach out, I threw my email in the chat and we can chat offline about that. I think whenever possible, the best scenario is to get the baby in front of the high fidelity camera so that we can provide the highest quality of care. But there will be situations, whether they just live too far or if the baby's unstable and unable to be discharged, where I think we can all try to work together to find a way that we could consider using smartphones to screen those babies. So I think we should take that conversation offline, because there is some preliminary evidence that that could work as at least as a triaging tool.
Thank you very much. Nana, can we get a phone number or a contact to put on the chat, so that if anyone is referring a baby for ROP screening, the patients don't get stressed out going round and round as you give your closing remarks?
Okay.
In the chat, we have emails from Arthur and PC Ahmed, so you can reach out to them for any further discussion.
Okay. I have put Muni's number here. Is it showing?
Yes.
Okay. So that's Muni. You can reach out to her if you're having any issues. All right. She's always ever ready and willing to help out. All right. So we have come to the end of the program. I must say we are so grateful at the turnout and at the interest shown. I just want to quickly say that, knowing the chat box, people were proudly putting up the youngest or the smallest gestational age or birth weight baby that they have saved in their facilities. So it's evident that we are saving more and more preterm infants. Adoma was saying earlier that perhaps we should reconsider the cutoff gestational age for abortion, because now, and I said, yeah, it's possible, but because now we're getting more and more 26 and 27 weekers surviving. But we should also keep in mind that in as much as we're saving them, we are also plying them with a lot of oxygen. So we should bear in mind, we might not see the effects of what we are doing now, but it could manifest in the long run. That is why we need to be very conscious about the oxygen we are using and the monitoring. So monitoring the baby on oxygen, ensuring that you're giving the least amount that would make the baby saturate better. And remember that in as much as you might have all the equipment, you can have a CPAP machine and all that, but there are other associated factors as well. This year's theme says breaking barriers, quality care for accessing quality care for every newborn. So I would urge that, yes, we rely a lot on donations, but in our own small way, we should also use this month of February to try and appeal funds. You can decide that, okay, we're going to appeal for funds and buy a vital sign monitor for the neonatal unit. We're going to appeal for funds and buy a conventional CPAP device for the neonatal unit. So by the end of November, I hope that we can also proudly come back. We're going to have another CPD, God willing, getting to the end of the month, where you can put in the chat box, oh, we managed to get a monitor for the neonatal unit. Oh, we managed to get this for the neonatal unit. So that at least we know that little by little, we're taking small steps to try and save our babies from the bad effects of too much oxygen use. So on that note, thank you so much for attending. Let's make November so purple, so that would increase awareness about prematurity and its complications. On behalf of the organizing committee, on behalf of PSG, I wish us all a very productive and celebratory World Prematurity Month. All the best. Thank you very much. Adumam Dano. Yeah, I hope I wasn't muted. Aduma. Whilst we're waiting, yes, thank you. Thank you very much, Dr. Aduma Kumbwating. I didn't think you were still on the call. Hey.
Yes, Nana, sorry, I was unavoidably unmuted. But thank you so much for your closing remark. And thank you so much, RHD, Dr. Aduma Kumbwating. Do we have any announcements from the regional secretary or the national secretary before we just finally drop off? Regional Secretary, if you will unmute yourself, do you have any announcements for us? In the meanwhile, like Dr. Nana said, let's make this a November to remember. So let's do this. When we meet again at the end of the month, instead of just posting how many preterms you're able to save this month, let us know how many pulse oximeters you bought, how many conventional CPAPs you bought. Please don't go and stand at Everpure or Verna or something and collect Baltic bottles and come and say that you have achieved 100 bottles this month. No. How many conventional bubble CPAP bottles you got? Sorry, bubble CPAP machines you got this month? How many pieces of equipment for preterm babies were you able to get this month? Let's go out there, do some advocacy. There are people with deep pockets, especially as we are in an election year, especially as we are rounding up, getting into Christmas. There are people with deep pockets. Let's approach them and let's get them to donate. PSG Secretary, please, do you have any announcements for us? Otherwise, we will call it an evening. Okay. On that note, kindly remember to get your CPD points because it's CPD accredited. If you have any challenges with it, you can reach out to your regional PSG rep and then work out how you can get your registration done. Kindly fill the evaluation form, and we wish you a happy November. May God bless us all, and may God give us all the strength it takes to make sure our preterms survive and thrive with good vision. Amen. Have a great evening, everyone.
2023, the Ashanti Regional Health Directorate, with support from UNICEF, started a program of linking preterm babies with community health officers, so that once the babies are discharged, we put their details on a referral platform that we have created. It's a WhatsApp platform. And then the community health officers of this discharged baby pick up the details of the baby, and they follow up with the caregivers. And their main duties include visiting these mothers to encourage them with the kangaroo mother care, and then also examining the children to pick up any danger signs that will require their reporting back to the health facility and all that.
Support for the for community health nurses has been tremendous. In fact, it had a very huge impact on our care of the preterm who have gone through the MBU discharge home. What we have observed is now the communication, the connection between the mothers and the babies who have been discharged and then the units is closer than it is some years back. And so we are not recording the complications that we used to record some years back. And we thank UNICEF for the support. We are now, babies are being brought in earlier. Danger signs are being seen earlier. And so interventions are rather rendered very early. And so we prevent long-term complications.
Preterm babies are babies that are delivered before 37 complete weeks. And all over the world, these babies, when they arrive, come with their own set of complications, just because they are born too soon. So sometimes they come with breathing difficulties. They come with feeding difficulties. They cannot keep themselves warm. They are more likely to develop what we call neonatal jaundice, which is yellowing of the skin. They have other problems that can be associated with the heart just because they are born too early. So when such babies arrive in our units, one of the major things we also have is with their mothers. Because from what they have heard in the community, these babies do not really survive.
Them be papa me. We should they come, they won't buy 5 months because no them could be taboo car, me the come plan is runner. None of the boys sending tonight, the baby. Miss Nubano be one for us, he has played there, and it does raining her. I may buy there, it does raining her. Because I want to miss you, Milly. Miss Susan, let me Susan. They are Mr. Barton, but here I am. And the night of freedom will send me to another month. I mean, slam on earth is great. I'm a one, papa, 5 months back. You did that.
Then I never want to say, I'm say, I can't copy and I are sending you. And losing a man that's one of the but if you know a Busiano and a unit to pa, as I say, that's never fear. ebi okura ne buku onim ne oba be ye na mo so mo adwen kyerɛ ne hia pa because wo na oba no enti mo ya besra mo ne ade no omo ba ne omo ye ni brano omo ba no ebi a adwen kyerɛ bi wo ho a betimi bi aye ne yi ebi a
Central App Clinic has been very instrumental in providing support for these babies in their families. Continuous monitoring is very important in caring for patients. However, there was a gap in providing care after the babies has been discharged. So there was the need to bridge that gap. Hence, before on the community health process, we do the follow-up home visit for us. And that has been very instrumental in providing care.
Wash. The court was not a baby almost in my edu. Almost a nurse a phone so be fear be me. But week be a number here warm. Send your mum poor music. And the archer bear 1 month, name the omaba. Starting on a week, in about 3 weeks, in about 1 month, in about 2 months. I feel the last pump for the 3 months here. Almost mean finding the MBB, Nankolano Maya Kama.
Each visit is essential, especially in the first week.
My minister, what is the food? I decided to share it. What she me, Papa, but to me, son, I'm Papa. Shadow Emma, me, I'm crying to me, and Cassie, yes, me, I'm a woman, my woman, but we bedroom feel. My minister, so a woman. The pen so I have a pimp send me dear, and where you might be given. Before when you cry, well, to me, extra me quite a fast step, among clan, Edwin. No, one, no, quite and you will be uncle because I'm city. You can move on, I'm fancy my woman, which I mean, I may buy it. From the home weight, cannot money weight. They are 178 grams. You want to be that's only wine punch fly. It's the other cry, I do on my own twin at 1 point. But I made a man pass. Now, for my mother, I'm a man. You will me when we put time and I'm so many 8 minutes. It make a way they share my phone crying. Almost all pretend say, oh, pretend, and not just our friend what did them.